Many organizations are being pressured to start thinking about some kind of framework around health equity because competitors are doing it. But the reality of this work is that it can't be a check the box to be very real. And if you're in healthcare and you want to see a change in outcomes, it requires an organization to look within themselves, to begin asking themselves hard questions. Are there practices within your organization that either continue to perpetuate some of the outcomes that we see or enable some of the implicit biases that exist?
Thank you for tuning in to another Meeting of the Minds. We are out here live at the Future of Mental Health Conference in Boston. The Future of Mental Health Conference, it very much covers like the intersection between behavioral health, a lot of the innovations that are going on in terms of payment reform that make things around health equity much more possible for organizations. And there's also, of course, a strong tie-in between data science and strategy. We're going to talk about all of those things today.
Hi, Chris. Thank you so much for having me.
What's really exciting about Tracy's work is that there is a specific program we're going to be digging deep into, the Neighbors in Healthcare program for Horizon Blue Cross Blue Shield, that puts boots on the ground in terms of community health. But that's not all it does. We're also talking about how to maintain these types of programs sustainably within organizations, how to make that business case, and how to work along with the data, metrics, and reporting, and of course work along with leadership to make these plans happen and grow.
Exactly. And Chris, I think what's so important is everyone understands that this is a journey. That this is not something that just happens through one particular program, but working towards equity and equitable care requires a multifaceted approach. It requires organizations to take a look at themselves and kind of align the needs of the community and then determine if the goals of that organization actually meet and address what the community actually wants.
Fantastic. Well, we're eager to dig into that subject and eager to actually pull out some of the themes that you discussed on stage today as well. But before we do that, Tracy, I just wanted to hear your background and what's led you to where you are today.
Sure. Well, definitely. The first thing I think is important for us people to understand is that we have to ground ourselves with who we are, why we do what we do. At Horizon, one of the things we always talk about is improving the health of our members. But I am a member, okay? I'm a member of Horizon. And what's important is what's happening to our members, patients, clients are happening to us. What I realized is when I went to social work school and started working with patients, member clients in the field, I realized that fear can be something that debilitates people, that doesn't allow them to pursue their dreams, doesn't allow them to reach whatever happiness looks like for them, or develop a sense of contentment. And I really made it a passion that wherever I went, or whatever field, that I would work with people to help them push past their fears. A lot of the fears that exist today are fears that we can't go into a church and pray. We can't go to a school without thinking about a mass shooter coming in. That's real fear that impacts the health of people. And I felt that I really needed to be an advocate. So as I moved throughout my career, I found myself in areas where I was consistently being an advocate. And that made me decide that talking about health equity was something that now is the time to really be the forger and the person that pushes forward and has those uncomfortable conversations, primarily with leadership.
That's an extremely important angle to come from, because I've spoken with people even in the upper echelons and healthcare boards that still have, like, we're talking about people with the C in front of their name and all of the titles and everything like that, but still afraid to be real about the issues that they find important and still be afraid to be that voice and that light within their organizations.
It's not easy. I mean, there are things, I think everybody has to know their organization and has to identify when the organization decides that they want to create a pledge or a commitment around health equity, because it is very much a buzzword now. Let's admit it, right? And then you can make some decisions about what organizations you want to partner with, getting the voice of the community at the head of the table, That, I think, is where structural changes start to occur if you really want to tackle health equity.
You know, you drive a strong point there too, because a lot of the fear that prevents people getting started from all kinds of equity initiatives is the fear of admitting that certain business processes, certain economics are biased in certain ways. Like, it seems very hard for organizations to take that first step in admitting that they were doing wrong in the first place. So how do you bring those conversations to light?
I think one of the things we did at Horizon was really starting with looking at the fact that traditional care was not working, right? So when you look at the costs that continue to escalate in healthcare, you have to start to identify what is the right system of care to actually change and modify behaviors. And if you consistently provide a program, and let's say the program really doesn't understand the root or the causes of the condition, then all you're doing is putting a Band-Aid on it. So one of the things I would suggest that any person who is thinking about starting to have a discussion about this is thinking about where your costs really are generated from, right? Because the disease is, yes, one aspect of it in healthcare, right, or the condition, but if you don't address what's impacting the person's ability to manage their health effectively, then what you're doing is you're just creating a million different Band-Aids, right? You're just putting Band-Aids on things without really hearing directly on what the root of the issue is. And that is something I think that's so imperative here. So that's the first step. One of the things we did was take a chance. That's the other thing. These types of programs where you're focused on addressing health equity, you're not going to see outcomes tomorrow. We're talking about structural racism that is embedded in the healthcare system for many, many years. To be able to say that one program is going to be able to change those outcomes tomorrow is really a fallacy. I think you have to be very real, and you have to decide whether it's a pilot and where you're getting the information from the community board organizations, from people who've had liked experiences to develop one strategy towards this work. The other piece I would say is really for the leaders of the organization to take a look at their organization and see how the organization is either supporting the growth and development of diverse leaders. If you don't have a diverse leadership team, you're very limited in your scope and your approach. To me, there's no other way around it.
Thank you for bringing that up. And especially, I think that a lot of our listeners, a lot of our audience are tired of like running back and forth between Band-Aids and Band-Aids, or chasing overly large promises that are doomed for failure. So to dig into something that focuses on the root causes of an issue, I think that's a perfect time to describe the Neighbors in Health program and what that entailed.
Sure, and thank you, Chris, for the question. It actually started with a pilot program. So 2 leaders within Horizon came together and said, what if we developed a program that incorporated community health workers into the care teams? Now, community health workers is not a new concept. It's been used abroad. Community health workers reflect the community. You can find community health workers at a school, at a church. They're those individuals that everyone just seems to gravitate to, and they do 1,000,001 different jobs, but they do it so well, and they have this succinct ability to connect with people within like the first 3 seconds of meeting them. There's something about them that they're naturally born to do. And this small pilot really looked at one geography, in Newark. And we decided that looking at the population based on 4 particular zip codes, specifically on a commercial population, and I want to kind of preface that. A commercial population tend to be seen as individuals that are working, right? So they have insurance because they work, and the likelihood is they don't have the same burdens or the same social determinants that a Medicaid member may have. Mm-hmm. What this approach taught us over a 2-year period was that these 2 community health workers who were hired engaged members at the point of contact in the hospital and really asked them, what are the things that are keeping you awake at night? It didn't start with, well, you're a diabetic and you need to go on this new treatment, so let's talk about getting you this new treatment. Do you have any barriers? It focused on the person. And what we heard from people who felt open and felt comfortable trusting that person was, yes, I'm having difficulty covering my rent. I'm having financial issues. It's challenging for me to provide food on the table. And what that program allowed us to do was see over the course of 2 years a decrease in total cost of care, as well as an increase in behavioral health services by connecting those members to resources within their community that they weren't aware even existed, or realizing that that was a part of what an insurance plan would do. So it was a collaboration between the hospitals and the community board organizations and payer.
Ultimately, how did that evolve? And I'm curious about like the use of data. The one thing that was exciting to me was that you discussed that overall there was a predictive model that was used to help the community health workers identify who's most likely to speak with. Can you speak to that?
Of course. So the pilot was called the Newark Initiative. That was with those 2 community health workers that I referenced. Mm-hmm. Because of those directional results, what we were able to do was to socialize this with our board, talk to other hospitals, and really start to develop what if we could scale this program? What if we could make this program bigger? What we saw was a 20% decrease in total cost of care and a 60% increase in behavioral health. And what we allude that to is the community health workers' ability to actually foster trust and really be able to kind of connect members to the appropriate resources so they utilize care appropriately. So the decision was made that we should dedicate $25 million to this program, now Neighbors in Health, over the course of 3 years. That required identifying partners, hospital partners, as well as coalitions that wanted to work with us. And Horizon covered 50% of the resources. So what that means is the hiring of the community health workers. Mm-hmm. We covered those salaries, and the partners that worked with us covered the additional. The thought behind this is that futuristically, these partners would be able to see the decreases in total cost of care and later work to build these programs into value-based programs.
So that's tremendous, and it digs into the heart of what some people might be looking for in terms of getting programs started. So it sounded like a much smaller effort.
It was an extremely small effort. So these 2 community health workers started. We didn't have a fancy platform. We didn't have predictive analytics at that time. It was a small shoestring budget. And what we did was look at our high utilized members, members who were frequenting the ER. And we used that as a guide, as a predictor of identifying our population. But very quickly, what we learned is by actually working with those hospital partners and socializing information about what social barriers were, we could get the care teams to also refer members into the program. So there was an educational experience going on here as well. A lot of it was speaking to physician teams about the impact of social drivers and social determinants of health on one's overall health outcome.
What's really interesting to me is always breaking past what you can pick up in a survey. And it sounds like having those conversations and identifying those social barriers. I'm curious on some of the social barriers that were identified in this process.
Sure. So right now, our top barriers are food insecurity, transportation, and financial insecurity. The program's been going for 3 years now, and consistently that has been the issue of the majority of our members. So with any of our members, we start with the crisis. Obviously, it's hard to get people to mobilize and move to begin to think about their care from a preventive standpoint, or going to the doctor because I need an annual well visit when they don't have enough food on the table, right? That is a priority. So our main concern is to identify and remove those crisis barriers. But then beyond that is to help individuals begin to see and identify goals for themselves. We're not here to tell you how to live your life, but but we're here to say there may be a better way. So some of the conversations community health workers have with members is really focused around what brings you joy. Tell me about goals. Sometimes we have members who will say, my goal is to lose 10 pounds to go to my daughter's wedding, right? Things like that. And the community health worker is working with the member to kind of identify and say, okay, if we're going to do that, there needs to be some changes that we both are in agreement with. So once a week, I'm going to meet you here, or you're going to do this, or twice a week, you're going to do this, or we're going to find healthier food. So it becomes a real shared relationship where this person has the ability to focus on empowering themselves when that relationship is over.
That speaks heavily to the power of being able to address real specific issues when you have the equipment to find out what's really going on. So it leads to another question. Now that this effort is in place and there is the funding behind it for it to be a major initiative, can you talk about how, like, the metrics and communications you have with leadership to sustain the program?
Sure. Well, I want to preface this by saying that sustaining a program like this doesn't come without its hardships, right? So I want to be really honest to folks that are doing this, whether you start out as a pilot, what you want to identify are some key metrics. What matters to the company? So in New Jersey, we have a real problem as it relates to maternal child health. We're 47th out of 50 states in terms of birthing outcomes, okay? And primarily for birthing persons and women. And that means a lot to us. So when we think about building metrics into any of our programs, we wanted to align with a couple of things. What's important to the state of New Jersey? What's important to us as the largest insurer in New Jersey? And if we want to reduce health disparities, how are we going to do that? So I would encourage anyone to look at their data first. Look at the pockets of the data where you're beginning to see those disparities. And you have to really desegregate the data. In the past, a lot of what we did was look at data from an aggregate. It wasn't looking at race, ethnicity, and language. And we're beginning to collect that data to help tell the story as it relates to the work that we're doing. So we're in the initial phases of that. So in terms of identifying metrics, you want to be able to say, if you believe that this program is going to improve and connect individuals to resources, how are we going to do that and how are we going to measure it? You want to measure it by race, ethnicity, and as well as SOGI data, even futuristically, because then you can determine if there are disparities. But what I would say is if you're looking to see if there's been an improvement in outcomes in terms of getting to wellness visits or a reduction in total cost or looking at a decrease in ER and inpatient, what you want to do is look at that based on those different criterias to help you determine if the interactions of the community health worker is truly motivating some of that. And sometimes it's hard to see that. But if you know that the larger majority of the individuals that you're engaging with, let's say, are Latino, or they're Black, you can begin to pinpoint how these points of care actually change the trajectory of the outcomes that you're seeing.
Overall, without asking the deeper question on how efforts affect subgroups, maybe an overall metric that looks really appealing, like it's masking something that's going on, disparaging a specific group.
And the funny thing is that until you desegregate that data, that's when you can really also begin to respond and make sure your programs are effectively answering the questions that the communities need. I mean, we know that our members experience a lot of health disparities, primarily those in Black and brown communities. We see the outcomes in, I would say, hypertension, obesity, and diabetes. We know that. But I think when we want to develop a program that responds effectively, we need to determine, do we need to have more physicians that look like the communities that they serve, or do we need to train physicians so that they understand the needs? You know, it's a combination of all of those things rather than just going back to the Band-Aid statement saying that, okay, all physicians need implicit bias training. You know, that's an aspect and it's important, but it doesn't necessarily mean that it's going to get you to the end point of what you need. After folks receive the training, then what? So it can't be this episodic kind of planning. The data helps you to decide after you put these interventions in place, what's really working.
And we know that that work is never done too.
It's ongoing.
But I do like to focus on the times that, you started looking and seeing the needle move, and there were times to celebrate. What would you say are some indicators or metrics that started making you proud of those broad efforts?
Yeah, we started working with an independent researcher. So that was aside from our internal analytics team that looks at the data. And what we're seeing is very directional. So we're seeing some results primarily in the areas of reduction in hospital days, where our community health workers have actually engaged those members at the point of care. We believe that that attributes to the decrease. One of the barriers that we see a lot of times is transportation when folks are in the hospital. Sometimes transportation isn't set up the time in which it needs to be to make sure it's an effective discharge. Sometimes the discharge occurs without taking into consideration the social barriers that are in the home. You can prescribe a medication for someone and that patient is so vulnerable, they're like, yes, I'm ready to take it, without realizing that it requires, let's say, refrigeration. It might be a medication that requires that, and maybe this person right now is in between homes and is in a hotel. And this is actually a real case that we had, where we were able to identify that served as a barrier. This person went to the hotel, was not able to keep the medication at the temperature needed, and unfortunately, you see a cyclical effect where they then either have to come back to the hospital or are sick again. So that was really a good indication for us to see that as a result from those interventions, we believe that there was a decrease in hospital days. The other I would say is overall management in some chronic conditions. And a lot of the results we're seeing right now was on a small population, so I want to be honest in the sense that it's still very much directional. Mm-hmm. We have our research team doing a broader, now that the program is 3 years. When they did that initial research, it was on a year. So now that it's 3 years and we have more robust data, we're looking to see what other points can we pull from the information we're seeing.
Could you talk about like the types of teams that you had to mobilize and potentially any pushback or resistance?
Well, I think these conversations around health equity are new. They're new for people. The topic is not a new one, but talking about it is new. So it creates an uncomfortable space for a lot of individuals. Even for myself, it's an uncomfortable topic because, I am the person that is also seen as that marginalized community, right? And I have individuals that are family and friends that are experience the healthcare system through the biases. So from the same perspective of thinking about it as a patient member client, it's also thinking about now I'm in a position of leadership. How do I mobilize that and how do I engage others in the conversation? So I would say it's really looking to leadership to begin to have some candid conversations, and it requires some of us to be vulnerable, to share stories about how you've been impacted by either your health or a loved one through the healthcare system. That's the first step I would say that is important. The other is getting a team of champions, people who really believe in this work. And sometimes it's not always the C-suite folks. Mm-hmm. It's looking for allies within your organization who believe in this work and who can start to build into the work in their day-to-day operations. So sometimes it starts with the language that we use, identifying and talking about patients. In the healthcare industry, there are a lot of things that we say that are not always as PC as we would like them to be. Mm-hmm. So I'll give you one example. It's identifying patients as a diabetic. Like, this is a diabetic, this is a hypertensive. This is just the way a lot of individuals have always spoken in the healthcare field with no malice intended. It's just a cultural thing. It's important that we start to identify this person as someone who has diabetes, versus identifying them based on a disease. That's the first step. The other I would say is looking at your care teams and extending and working with non-traditional resources. This work required us to begin to engage with clergy. At the height of the pandemic, we started working with churches, we started working with schools to be able to socialize the vaccine. At the height of the pandemic, now you can get a vaccine anywhere, right? But at the height of the pandemic, there were communities that did not have access to the vaccine. And one of the things we had to do is be very nimble and be flexible. And we started working with non-traditional, partners, again, churches, clergy, CBOs, bringing the vaccine to the community. Having folks come in and have conversations about why it's important to receive the vaccine or how to make an informed decision about receiving the vaccine. So it's looking at who can be your allies, who can be your ambassadors, your champions around this work. But it took a lot of socializing and education within the organization, and it still requires more because the needs of the community are ever changing. So it might be today looking at specific access to medications and how they're being prescribed by certain physicians. Tomorrow it may be looking at, transportation and housing in this particular area is a barrier. So it's multifaceted.
One thing that you really touched on a little bit earlier was on using this data and understanding and identifying where these challenges existed, and then working along with these teams to start addressing these issues. I mean, I thought that was a really powerful point.
Thank you.
So there's the Neighbors program that you launched, but I'm curious if there are like plans around expansion of this program or other programs that you might be looking into. We've talked about a program that's in progress, but I'm just curious about where you think that the health equity conversation is going to be leading.
Yeah, well, I think the first thing is the fact that we're having the conversation about health equity in every area. That's important. So it doesn't just live in a program. That is the goal, that health equity becomes the company's footprint, that it becomes part of the organization in terms of thinking about how they deliver on work that they're doing. So in your actuarial department, in your communications department, like these are different areas where we're starting to expand conversations around health equity, that it's socialized for the organization. Our CEO's been having conversations about how he is addressing health equity. So it's not, again, just living in one particular area. My department happens to be community health, and that's where it started, but the intent is that health equity permeates throughout the organization. So how we contract with vendors, asking them questions about how they're promoting health equity and how they're impacting workforce development. Hiring diverse populations is really important, and we should be able to ask that question of individuals that we contract with, what their health equity stance is, So collectively, this work becomes not just what Horizon is doing, but it becomes almost contagious, like it's a body of work that everyone's working on. So I would say that that's an important piece of this. The other aspect is thinking about disaggregating that data that I mentioned. Based on what we find over time, it is going to continue to dictate new programs that we develop. One of the things that we are most recently proud of is expanding the benefits to doulas, helping a birthing person through delivery, right? It's providing them with insight and cultural support that meets that person's needs during the delivery process. And they can be working with a birthing person or woman throughout the pregnancy. They serve as an advocate. They basically are that person that can be there throughout the delivery, making sure that this person is focused on the end point of what's going to happen, which is a safe delivery. And we believe that it's one of the ways to bridge some of the health equity gaps that we see. We know often in maternal child health space that unfortunately people of color are not listened to. And that's one of the reasons why we see some of the health outcomes that we see. And it goes beyond all socioeconomic. So it doesn't have anything to do with whether or not, this birthing person or Black woman is, extremely well-to-do, or if this person is not doing as well financially. But the issue is that this person isn't being listened to. So we believe that doulas serve as that support. It is not the only solution, but it is one of the solutions. So those are some of the programs that we're looking into, but I want to just say it's a multifaceted approach and ongoing. That's not just baked into programs, it's baked into how you're wired in thinking about contracting with, physician partners, programs that you develop, but even just the mindset of the overall organization.
Well, it sounds like if people are passionate about launching programs and identifying where they should start, it just seems like with the way you're describing it, there's a mosaic of health equity opportunities that are in the data waiting to be discovered.
Definitely. And I think, some people may not think that this is, really attractive, but you have to put the care back in healthcare. Like that is the reality of what we're doing, And it starts with identifying what people really need. And if we understand that structural racism is what dictates how individuals are not only treated, but how they utilize the healthcare system, every program that you develop will be just that. It'll be a program. It won't get to the root. You won't see the change in the outcomes. You won't see the improvements that you're looking for. And this is the way that we have to begin to look at care.
Thank you. Yeah, and we can't address structural racism with our heads in the sand. And if when we start to look at that type of data, then you start seeing what the ethnic breakdown is, how certain populations are impacted, and ultimately who the level of the population that is unwilling to self-report because of a lack of faith in that system's ability to have their interest at heart. But there is a major question that we ask everyone. I'm excited to hear your answer because of all the work that you've done so far. Yes. If you had a magic wand that could change anything about our healthcare system today, about the way healthcare is delivered, what would that be?
I think it's the first thing is recognizing that people, regardless of race, regardless of ethnicity, language spoken, that they deserve the right to be treated equitably and recognized as an individual that deserves care, that it is their right. We all have rights. I've seen cases where people provide more care to animals, and I'm not taking away from animals, but the reality is that there are humans and there's a life behind the person you see beyond their skin. There's a human there, right? And my thought would be in the healthcare system that no one should be afraid to go into a doctor's office or to go into a hospital because they fear that the color of their skin is going to determine how they're treated. I would love for the four walls of the doctor's office or the hospital to be that welcoming place that, yes, you go to truly when you're sick, but you don't have to fear or think about what's the story I'm going to tell so I get the best care possible. And this is real. I've spoken to friends, family that look like me, and they've said and rehearsed like what they're going to say to the doctor so that they self-report in a way that seems honest, that they come off as their best self because they already feel like they're being judged. So I know that's not a one-word answer. It's not necessarily focused on payment reform. I think those things come, but I think first you have to see people as people, and you have to think about who that person is as your mother, as your aunt, as your sister, as your husband, your wife, significant other. If people start to see people as humans, then I think care would be rendered in a way that would be so much better.
Absolutely strong point, because while the economic incentives and things like that, that's good for making certain things happen when they need to happen, it won't happen if the physician is disregarding you because you're a Black woman or your race or gender or sex and gender minority status, etc.
And you said a magic wand, so I said, I'm got to think big. Hopefully over time we will begin to see that, at least in the healthcare system. I think payment motivates change, unfortunately. But I think first we really have to align with seeing individuals as individuals and people as people.
Well, I think that's a very refreshing answer, and as people grow into themselves or they grow out, because like we really don't want those people who harbor those biases. We don't want them in our organizations, and they're unable to deliver care effectively. I'll just speak from my mom's perspective, where she was discriminated against in a healthcare situation. I can't get deep into the specifics, but when that happens, when you've undergone that experience, it sours everything else that person will ever say to you again. So especially for that coming from your healthcare provider, they are no longer your healthcare provider at that point. They are unable to do their job because they let let bias seep into their process.
Exactly. And I think we are at a point where we can not penalize folks for having biases, because the realization is we all have them, right? But when they permeate how you deliver care, that's where the problem exists. So I'm all for making individuals aware that implicit bias exists in healthcare. I'm all for making programs that focus on addressing and educating people, but you have to make sure that those programs meet the needs of the individuals that they serve. But also, once you identify that you have those biases, what are you going to do to address them? You know, some of us will never erase them, but they can't permeate into your work.
When it manifests as harm is when we start turning on the sirens.
And there are some people who don't even realize that the biases can be harmful. And sometimes it's not always harmful, it's subtle. You know what I mean? So it might be the questions that the doctor asks. It doesn't seem as it caused harm to the person in a physical sense, but mentally, if you're being asked a question that you don't think your white counterpart is being asked, that creates a harm to you, because the next time you go in there, you're like, okay, I'm not going to really reveal everything about myself because of the way that I'm being treated.
This has been such a great conversation. There's so many steps. There's so many things that I think people can take away from this and start thinking about, considering, planning for in their own organization. So I really thank you for that. It's healthcare, and there's a certain way that we're prescribed to act and speak and think, and it's refreshing to have a real conversation. So appreciate you coming on with us.
You're so welcome, and thank you for having me. And like I said, this is a journey. So I think any organization that tries to do this with a quick fix, it's not going to yield the results that you're looking for.
Absolutely true. And again, another thank you also for Future of Mental Health for making this kind of conversation possible and providing a space for leaders in the space to be real about these issues.